Welcome to the TCTAP 2019 wrap-up interview focusing on the imaging. I am Hong, Severance Cardiovascular Hospital. My co-moderator is the Akiko. Akiko Maehara is a CRF from New York. And we invite two distinguished faculty. One is Dr.
Akasaka.
Dr. Akasaka,
yes,
from Japan, and Dr. Jang, Professor Jang from the Mass General in Harvard. Okay, actually, to invite the speaker is very famous. So we will start a lot of discussion about the focus in imaging. First of all, we listened to a very interesting topic about the layered plaque in the acute coronary syndrome patient. Personally, is a lot of the shocking for me is a new insight to patient care. First of all, I'd like to present about what is the definition, what is the clinical impact of the layered plaque, particularly in the acute coronary syndrome patient. Dr. Jang, please.
Thank you, Dr. Hong. So, layered plaque is something that we have been interested in for years, actually over 10 years. But we needed a validation study, and the validation study came from actually Professor Akasaka's group. Believe it or not, we had, when I felt we had enough patients, the 376 came from 1108, so over 1,100 patients. Is selected 376 presented with acute coronary syndrome in whom culprit lesion was imaged. So we have prepared a manuscript, and then Professor Akasaka's paper, Shimokado,
yes,
just came out right on time.
Mm-hmm.
So we actually, before the publication came out, we were able to incorporate the important validation study just to support our data. So the data is patients who presented with acute coronary syndrome. When you see a layer pattern, and Professor Akasaka prefers to call heel plaque, we found in 28% of patients in the culprit lesion, the others did not have. And those patients with layered culprit plaque had higher prevalence of other plaque vulnerability at the culprit lesion. And then subsequently we studied non-culprit plaque and also a different cohort of patients with stable angina. So there is distinct difference, the clinical significance of culprit layer plaque in patients presented with ACS and compared to those presented with stable angina. Now, another subset of patients we studied in collaboration with Professor Filippo Crea, my former fellow Rocco Vergallo, published last month in JAMA Cardiology. So we divided patients into three groups: patients with ACS, just like the patient that I presented today, and then latent acute MI, means acute MI at least 3 years prior to the current study, and then stable angina. What that study demonstrates is patients with ACS with layered plaque, they have impaired protective mechanism. In other words, at the time of plaque disruption, whatever that is, plaque rupture, erosion, or calcified plaque, we prefer calcified plaque to calcified nodule. Because calcified nodule is just one subset of calcified plaque in ACS. They have impaired protective mechanism, in other words, impaired anti-thrombotic system in their body. So at the time of plaque disruption, massive thrombogenic substrate will be exposed with larger, most likely larger amount of thrombus, but body doesn't have a system to deal with this large thrombotic burden, and therefore they form an occlusive thrombus and clinical presentation of ACS. Whereas patients with a previous MI, at least 3 years or longer ago, they have features of plaque vulnerability, such as lipid-rich plaque TICFA. However, because they have better protective mechanism. Even though plaque ruptures, it doesn't form a thrombus big enough to occlude the lumen and therefore clinical presentation. Whereas the stable angina patient, they have features of plaque, lower prevalence of plaque vulnerability. So our study looked at specifically plaque phenotype of patients presented with ACS, layered and non-layered. And then layered subgroup had features, clinical, angiographic, and OCT features of pan-vascular vulnerability, both morphologically and presumably systematically.
Usually in the acute coronary syndrome patient, in the culprit or lesion or infant-related lesion, the underlying mechanism, plaque rupture or erosion and the casping nodule. So
That's
how do
plaque.
And layered plaque?
No. Those.
How do we classify the usually this lesion is?
So layered plaque, as I showed you during my presentation, you can see associated plaque rupture. And when you look at the residual plaque morphology very carefully, then you see layers with different optical properties.
Okay, it's a different classification.
Yes. So you look at from different angle.
And the second,
I'm sorry. Or in the patient who had plaque rupture with without healed plaque together. That's a way to.
Say that again.
If the patient having the plaque rupture and thrombotic event, at that segment we have some patient having already some sort of the layer, some patient not.
Yeah, of course.
And that's same for the, do you think that's the same for the erosion? Meaning in the erosion patient, sometimes we see already some sort of the organized thrombus, or we couldn't differentiate this is healed plaque or already organized thrombus. Because most of the erosion patient come up, not most, but some of the erosion patients come up to the hospital a little bit late compared to the rupture patient. So some of the thrombus could already like days late. So in the erosive cases, do you see the nice erosive thrombotic event plus minus healed plaque? Is
So
this correct?
The
Yeah.
time frame that we are dealing with may be hours or days. I don't think OCT is sensitive enough to be able to tell this is partially organized thrombus or this is more mature thrombus
Yes,
versus
exactly, yes.
collagen.
Yes.
And as you know, initial phenotype is collagen type 3, which is replaced by collagen type 1.
Yes.
So these time frames, I don't think OCT really can tell. All
exact,
OCT can
yes.
tell is there are layers with different optical
Yeah,
intensity.
I totally agree. So I think to be more specific for the classification, out of all ACS underlying plaque should be plaque rupture with without healed plaque, and plaque erosion with without healed plaque. But so-called layered or healed plaque may organize thrombus or may already early stage of the like the proteoglycan-rich healed plaque. Is this agreeable?
Yes.
Yeah.
Anyhow,
Oh, yeah.
for
That's
the
something like this.
non-imaging the interventionist, we need some clear the definition of the plaque type. What I mean is that if I do not listen to your presentation, simply think about that this is a plaque rupture or this is a erosion mainly, but there is additional layered plaque. Where is it? Where is the position of it? It's a little bit the confusion. So we
Same
need
with the culprit plaque.
yes, it's clearly and define and what it is and.
Our research work started the vulnerable plaque definition, right? By OCT, we can see a lot of thin cap fibroadenoma. Only a few may meet the acute coronary syndrome during a long-term follow-up, right? But some may have a rupture, but we cannot identify clinically. And during follow-up by OCT, we can identify some different tissue at the thin cap portion. That means silent rupture and healing may occur, right? That may clearly explain that layered pattern.
Yeah, also that's quite important when we talk like the statin therapy. And then many times we are thinking the sickness of the cap is going to be sick.
Right,
That's kind
right.
of the healing process or make it stabilize
Right.
of the very vulnerable plaques such as
Right,
lipidic.
right.
But that's actually two components. One is really cap itself looks thicker and then no change of the lipid. Or sometimes we see the new layer on the top of the
Right.
lipidic plaque and
Right.
that's actually stabilized or temporarily seems to be thicker cap compared to before.
As Professor Jang said, we can differentiate the different optical pattern, and it demonstrate. We did an autopsy examination, and it means the different collagen type. As he said, we cannot identify from immature collagen to the mature collagen. How long does it take? We don't know. But anyway, we can identify immature collagen at the top of the surface of the plaque. It means
In the expansion of the stabilization of the vulnerable plaque, like in the thin cap, what is the role of the layered plaque in the upper layer? What about with the more strong, the high intensity statin or lower, and what is the change?
Good question. Don't know. But the high intensity or less high intensity, it makes difference in terms of plaque stabilization. That's not the scope of our discussion, but at least in the United States, at least in Boston, anybody coming with ACS, we hit hard with high intensity statin. Everybody on either Atorva 80 or Rosova 40, and if needed, we down titrate. So the less intense statin therapy versus high intensity statin therapy is interesting from mechanistic perspective, but clinically it's almost irrelevant.
Okay, the next I'd like to invite talk about Dr. Akasaka.
Yes.
When we listen that you are talking about the role of the OCT in the pre and post intervention procedure, a lot of the software, I think it is very interesting for me because the reason why using the software expand the use of the OCT person. What I mean is that he does not, if they does not have much knowledge or experience, but the software, they answer everything clearly.
Yeah, right.
So they can easily use
Right.
and the use of the OCT during the PCI procedure is more comfortable. And so what is the best the software for the young interventionist in the real practice?
Yeah. As you told, I think there are lots of artificial intelligence, right? They automatically calculate the lumen diameter and the position of the stent, and also the expansion condition and with an angio. So angio co-registration gives us very important information. Anyway, when we put a stent, we need an angio, right? Without angio, sometimes very difficult. So the co-registration is also very important. And the expansion, under expansion is the most important factor to relate the prognosis, right? So we have to avoid under expansion. And the recent OCT gives us the under expansion by the color-coded image. And also, we already have a position indicator. It demonstrates the apposition condition. If we have a good apposition, that's the machine demonstrates a white color. And if there are big incomplete apposition, we can identify by the red color. So it is very useful for the beginner of the PCI. What is the problem, right? And we can get a very good result. Yeah.
Automatically presentation of the information of the OCT is very useful to
Right.
the young interventionists.
Yes.
So the easy to adapt the more excellent job in their procedure.
Even in the complex lesion
Right,
procedure.
right.
And also, at the moment, I think the bifurcation lesion treatment also one of the issue, right? The recent stent makes a very good result. However, still a little bit poor prognosis if we deal with bifurcation lesion treatment compared with a simple lesion. At that time, recent development of OCT gives us a strut condition on the surface of the side branch and also the position of the wire very well. Almost 70 to 80% we can identify the wire position of the side branch. So at that time, we have to think about what is the best treatment at the side branch orifice, right? As I told at the discussion, the main branch condition is most important. We have to think about the array of the strut to keep the good condition. And in addition, if we can treat the side branch, we can get a much better result. Yes.
The bifurcation is a good indication for to use of the OCT.
Yes.
I agree. And
Yeah.
additionally, in the calcific lesion.
Yes.
Calcific lesion, and Akiko present a lot of the information about the severity of the calcium. Did you have any comment? What I mean is that in the depending on the severity of the calcium, we have to change the treatment strategy or selection of some specific atherectomy devices. So what I mean is rotational atherectomy or orbital atherectomy or shockwave balloon, because the direct shockwave balloon is cover the whole the lumen length, but the rotational atherectomy is some unidirectional, so does not achieve a target the decalcification. So any your opinion?
Yeah, I think make it simple. I think key is probably using the orbitory or rotablator or probably in the future the shockwave. I don't think that's a big difference between one and the other. Importance is when we need such additional things. And probably you already know if your device doesn't cross, that's the time to consider. I think probably we learn for a long time, but probably OCT or IVAS can tell more detail, which is more likely. That's good for the young generation to understand better. So yeah, that's it.
Any other opinion?
Yes. Yeah, we can measure not only the presence of the calcium, we can measure the thickness of calcium. When we obtain a good stent expansion, if we put a stent, making a crack is very important. And also, if we try to select a much bigger bar size, we can guarantee the safety because of the thickness of calcium, right? It is very important for the beginner to do such complex treatment. Yes.
Dr. Jang, any other opinion about?
Yes, I have a question to Professor Akasaka.
Yes.
So all this new software make the system very user-friendly. But ultimate goal is to improve outcome.
Yes, that's right.
Not make a user-friendly system.
Right.
So IVUS, without all those softwares, at least meta-analysis showed improved hard endpoint. OCT yet hasn't proven it is superior to IVUS.
At the moment, we are on the way, right? Some report from UK demonstrated the superiority of OCT
Only
compared
one
to
study,
yes. So we have to have such study, right? At the moment, as you told, there are only non-inferiority, but it's an old system. Therefore, we have to apply such a system to the very complex region. Compared with IVUS and OCT, we will get a result, right?
And what's your prediction? Do you think OCT will be a winner?
I hope so.
No, not also, based on the data.
Right, I believe. But the recent stent is a very wonderful result. So we have a very huge number to demonstrate the superiority. It might be very difficult.
Right.
Yeah.
That's my prediction too.
Yeah.
With improvement in stents and technique, the incremental benefit of anything additional will get smaller.
Yeah. So we are focusing on the specific condition, as Akiko said, calcified lesion, or long diffuse lesion or bifurcation. At that time, we can demonstrate some superiority, much easier, right?
Okay, I think because of the time now, I'm moving to you. So please give us a comment or advice how we can predict in terms of the healing of the stent by OCT. So please summarize your presentation and your thought. I think I really would hear your real clinical thought. What is your practical advice?
Okay, practically, the stent short coverage by OCT is very important to determine the patient outcome and determine the duration of dual antiplatelet therapy after the drug-eluting stent, particularly nowadays. So we need a lot of the field to investigate and prove it. So I think this is just the beginning. When some new stent was in the market, that stent should be proved, evaluated using the OCT. That is my concern.
I have a few comments on it. So the short duration DAPT is good for a specific population with high risk for bleeding. So as you know from DAPT trial, 50% of MACE comes from stent-related lesion, but the other 50% comes from non-culprit lesion.
Right.
So that means, non-culprit plaque rupture or erosion. If there is no strong contraindication, at least in my practice, I continue DAPT way beyond the year to suppress the other 50% and plus culprit lesion related. That's number one. So in other words, people with low risk for bleeding, I don't think we need to try to shorten the DAPT duration. Number two is the tissue, whatever that is, covers stent struts. We don't know whether that tissue itself is thrombogenic, right?
Correct.
So the fact that stent strut is covered doesn't mean that area is non-thrombogenic. In fact, my former fellow Masamichi Takano showed with serial angioscopy, the area where the thrombus was visualized, follow-up, that thrombus disappeared. However, in the area in earlier follow-up that did not have any thrombus, no thrombus was formed. So I don't know the tissue, whatever that is, the fact that it is covered means, I feel comfortable stopping DAPT. I'm not sure.
Yes. Unmet need in the real practice, what I mean is that current guideline is too much emphasize more dual antiplatelet therapy duration. The other side, right, in the high risk patient, high bleeding risk patient, then it is actually real, the emphasis of the more prolonged dual, strong dual antiplatelet, correct. However, there is no evidence about the short duration of dual antiplatelet therapy. So some patient, some patient had the elderly patient. He's physically healthy. Lesion is short, but the heart problem is fixed by stent. And 1 month later, he visits the outpatient. I have another problem. I have a prostate. I have a colon polyp. I need a surgery or some procedure. There is another proportion of the patient needed, but there is no evidence, no proof. So, the real clinician, there is no evidence, but you have to use a prolonged dual antiplatelet more one. So, actually, you said there is some specific patient needed the prolonged patient. However, we have to take care of the other patient needs a short duration of. Therefore, we have to clarify who is the subgroup. Who is the subgroup? Maybe short duration of dual antiplatelet, quite good. But still, there is no evidence. There is another field.
I think totally agree. When we see the very early stage OCT appearance, early stage like 1 month, 2 months, there is a very big variation per patient or per region in terms of the healing. But after like 3 months, 4 months, 5 months, they're very homogeneous. And then I think most important question, who is good enough? Who is really bad in early stage? And then in the patient population who had the high risk bleeding. So to do this, I think we have confident level to say yes or no. Yeah.
Some patient, 50 years, the healthy So the clinical presentation non-STEMI. Stent was deployed in mid-area stent length 3.5 and 18. That's it. But your clinical presentation non-STEMI, you have to prolong the foreign plate therapy more than 1 year. But this is actually some different population. But according to the guideline, now you have to take a more strong.
Actually, the patient that you talked about, in my practice, I continue that. For the, when you do one corporate vessel pullback, you see 1.4 chance of lipid-rich plaque. When it gets disrupted, then you want to have DAPT on board.
Maybe. So anyhow, that patient needs. I want to stop we have to think about only academic or our side. We have to look at the patient need.
But DAPT study showed patients do benefit.
Actually, we want to.
Recently, the stop DAPT study in Japan.
Yeah.
It's recommended the short DAPT. So at the moment, we have no fixed result, right? We have to have still investigation.
Right. We need the data.
Yeah.
Okay, anyhow, thank you for the nice talk.
Thank you.
Mr. Dr. Jang and Dr. Akasaka, Akiko.
And Dr. Hong.
Thank you.
Thank you.